Okay, we might make a start if everyone's happy with that. Just do a little bit of housekeeping before I start. I shall put up the remaining lectures or the lecture notes for the remaining lectures, that is lectures in week 2, 3 and 4, which are the remaining respiratory lectures. I'll put them up on LMS by no later than the end of tomorrow. So you'll have them all by the end of tomorrow, and appropriately requested, I'll put them 3 per page and 1 per page landscape. So I'll make sure I can do that. The other thing is, now that I'm second day back and I'm hopefully back in my groove, I'll be much more able to run at an appropriate pace, which means that I can catch up, but that's perfectly okay. The other thing's, I hope you don't mind, I put the 2 screens up. Doesn't really matter, but obviously it's this screen to my right, your left, that is recorded, but just in case you're sitting on the other side of the lecture theatre. Again, there must have been a rule in the university to continue the light being able to be monitored by the desk at the front, because I can't dim the lights in this theatre either. I'll certainly put the request in to see if it's just me being stupid or the situation, but Stuart couldn't do it either. So we'll have to live with this amount of light at the front until I find out whether this is a policy or not. Anyway, we can cope. We have the processes and means to cope. So what this lecture is all going to be about is the mechanics of breathing. Now, there's a lot to show you, I guess, compared to some of the other lectures I will undertake, but the theory behind these lectures or these photos that underpin the content is not particularly difficult. In fact, for some of you who've done physiology in Year 1 and some of you who've done anatomy alongside physiology, you might find this fairly straightforward. I hope you do. We'll be sneaking in bits of information, but it certainly underpins the rest of the lectures in respiration, which do crank up in their complexity. If you're new to physiology this semester and this year, certainly happy to receive any questions or happy to discuss it with you at another time in the tutes or in my office, should you need to avail yourself of that resource. So, open invitation. Inspiration, as we discussed yesterday, very quickly, it involves 2 key skeletal muscles, the diaphragm and the external intercostals. You probably inferred that there are internal intercostals, and they'll become relevant to a very small degree at another time. But certainly the diaphragm and external intercostals contract, which aims to elevate the rib cage, depress the diaphragm, and concomitantly enlarge the thoracic cavity. We'll explore that in detail as we go through. This is an active process. It requires action potential innervation to the skeletal muscles, and it requires work and hence ATP. Not in that order. Quiet expiration, and I do underline quiet expiration as distinct from forced expiration, which of course is active. We'll talk about that again later. But quiet expiration is, in contrast to inspiration, a passive process. It's all about relaxation of the same muscles and relying on surface tension and elastic recoil to reduce the volume and size of the lungs and the alveoli that make up the lungs. Now, online I would have spoken to you about the elastic nature of the lung. So obviously, like anything elastic, if you stretch it, it wants to recoil. The alveoli are surrounded by elastic tissues. They want to do the same. That's passive. Similarly, we online and looked at very briefly yesterday, surface tension is the cohesive forces of water molecules. They always want to attract each other or become closer together. And obviously, if you inflate an alveoli, you're stretching or separating the water molecules. What do they want to do? Come back together again. The only way they can do that in a spherical shape is to reduce the size of the alveoli. So surface tension and elasticity always want to shrink or reduce the size of the alveoli that make up the lung. It's all passive. We don't have to worry about it. Let's look at that schematically. And I've taken a diagram from Marieb because it just served my purpose in this lecture better. There is a diagram in Silverthorne that you will look at, which is referenced here, figure 17.8, which gives you the same information. I've just made a decision that this diagram is a little better for my purposes in a lecture. And if we particularly look at the middle and right-hand panels, because they're the ones that are relevant, the left-hand notes I will work through as we progress through the arguments. But clearly you can see the diaphragm, as I flagged yesterday. It's a flat skeletal muscle fixed at the lateral ends. It's shaped like a dome. Shorten the fibres, the dome descends, moves inferiorly downwards. That's a tautology, I know that. We've got the external intercostals running perpendicular to the ribs. Shorten those fibres. The ribs being fixed superiorly means you shorten all these fibres between the ribs and the rib cage will move upwards and outwards, rather like a bucket handle. And what we're particularly interested in is the resultant change in the shape and hence volume of the thoracic cavity. And so the right-hand panel tells you or shows you the lateral dimensions and therefore the internal size of the cavity of the thorax. Now, if we contrast that, and really I'm not going to be any more technical than contrast it with the next slide, which shows the diagram of our thoracic cage or cavity in the relaxed state, that is during expiration, where the fibres of the diaphragm lengthen passively, becomes more dome-shaped, pushes superiorly. The external intercostal fibres lengthen passively, and hence the rib cage moves downwards and flattens inwards. So the sternum moves inwards, closer to the dorsal part of the cavity. And the resultant volume of the rib cage or the thoracic cavity reduces. Now, I know this is lowbrow in terms of technology, but I'm just going to flick backwards and forwards and ask you to look at the right-hand panel and you can see the resultant changes to the volume. And again, I know this is lowbrow, but larger volume, smaller volume, that's all we're talking about. Now, that in itself is fairly straightforward. It's meant to be. So what you and I do is control the volume of the thoracic cavity. We have no direct control over the lungs. So obviously, for this to work, the volume of the lungs, and by lungs I mean alveoli, which make up the lungs, they must also increase and decrease in volume according to the size of the thorax. So put really simply, if the thoracic cavity is getting bigger, that's going to make all the alveoli get bigger as well. Now that can only work if the lungs are attached to the thoracic wall. And obviously they are. So now we're going to explore how the lungs are attached to the thoracic wall, which then allows us to understand why when we increase the size or decrease the size of the thorax, we are also increasing or decreasing the size of the alveoli inside the lungs, because the two are connected. How are they connected? Very straightforward, again. But many of you will say, oh, anatomy again. Maybe you'll say, yippee, anatomy again, if you're like me. Oh, gosh, anatomy again. Depends on how much you like anatomy. Move on, John. No time to waste. Marieb figure 1.9. Now, the reason for this is because it's not part of the respiratory system. It's relevant to the whole body structure and function. So it's chapter 1, Marieb, Silverthorne, chapter 3. It is nothing more than a refresher. It tells you that the body has cavities. And we have the dorsal cavities in this picture, this diagram indicated in yellow, which contain the brain and the spinal cord. The difference between the dorsal cavity and ventral cavities, coloured in red, is nothing more than the membranes that connect them to the wall of the cavity, connect the organs to the wall of the cavity. The ventral body cavities are relevant to respiration. We have the thoracic cavity. You've obviously got the abdominal and pelvic cavities. We're interested in the thoracic cavity, to which I'm pointing, which contains the two lungs, the bronchi, and the heart. We're interested in those cavities that contain the lungs. Now, as you know, the organs within any of these cavities don't just float there and sink to the bottom. They obviously have to be connected to the walls of the cavities. For the dorsal cavity, obviously it's great protection, so that we're protecting our brain and spinal cord. But for the thoracic cavity, as I said, really important because it means whatever you do to the size of the thorax, the lungs will follow. How are they connected? Now, many of you are aware that the body cavities are lined with something called a serous membrane. And again, if you haven't come across this in your studies thus far, don't worry, it's nothing more complex than I'm going to say. So we have a serous membrane. Now, the classical way to understand the relevance of these membranes is indicated by this small diagram I've input into the larger one, and will be looked at again in the next overhead. The analogy Silverthorne uses, and any other textbook you'll use, is think of the lungs or the body organ, the body structure or organ as your fist. The serous membrane is a balloon, so it's one membrane shaped like a balloon. If you punch your fist or the lungs into that membrane, you end up enveloping the organ. I'm using my fingers to point, which helps nobody. The lung is analogous to your hand. It's closely aligned with one part of the serous membrane. Continuing with it is the other part of the serous membrane, which is firmly adherent to the cavity wall. And there's your answer. Why and how are the lungs connected to the thoracic cavity? Well, the why, so that they follow their shape and volume. How? Via these serous membranes that connect the two together. Now, we give the serous membranes a name for the thorax. They've got a name anywhere, but we're only interested in the thorax. And they're called the visceral membranes, which are the membranes connected to the lung, and the parietal membranes, which are the membranes connected to the thoracic wall. So let's look at the next diagram, which outlines it a little more clearly now we've established the idea. Fluid-filled balloon, fist. So this is the pleural membranes. Now we call them serous membranes as a generic term. Pleura is specific for the thoracic cavity. So the pleural membranes are the serous membranes in the thoracic cavity surrounding the lungs. Lungs, fist, push them in, you get a firm adherence of the membrane to both the organ and the thoracic wall. Parietal pleura is the pleural membranes connected to the thoracic wall and diaphragm. The visceral pleura connected to the external components of the lung tissue. Now notice they're fluid-filled balloons. Well, in fact, they're not balloons at all. They're fluid-filled serous membranes. And that's no accident. So the pleura, now, firstly, before I go into that, this is a really exaggerated picture. I mean, by looking at this diagram, which is Widmeyer and Silverthorne's, you kind of think, wow, the pleura must be almost as thick as your lung. It must be centimetres thick. It's not. It's less than a millimetre thick. In fact, the sum total of all the fluid that surrounds the lungs is probably no more than maybe a tablespoon of liquid, 20 mils or so, 20, 25 mils. So very thin walls, but obviously if they made it representative of the actual anatomy, we wouldn't be able to see it in our diagram. So don't be misled. Irrespective of the size of the pleural cavity, why is it filled with fluid? Well, I guess what have we established about the lungs? What do lungs generally want to do? Deflate, because they're elastic and the alveoli have surface tension. They're always wanting to shrink. But they're stuck via these membranes, which, if they were filled with air, what can air do very effectively? Expand. Like if you get a syringe full of air close it off and pull on the plunger, you're very easily able to expand that air volume. The molecules just separate apart more than they normally do. So what would happen if there was air in that pleural cavity? The lungs would simply recoil and collapse. That's what happens when, not when, and hopefully not if, but if somebody has a penetrating injury, be it a stab wound or breaking their ribs or collarbone, clavicle, which perforates the pleural membranes and it exposes to the outside environment, air gets sucked in and the lungs collapse. And that's why people do suffer often collapsed lungs as a consequence of damage to the pleural membranes. To prevent that, you need water, because what can't water do that air does? Stretch or expand. Get your same syringe, fill it with water and try and compress it or expand it, it's impossible, or nearly impossible. So it's really important that the parietal pleural cavity, so again the pleural cavity is filled with fluid because it stops the lungs from collapsing because of its non-expansive nature of water. By water, it's not pure water, obviously, it's more like serum, extracellular fluid, but it has the same composition, if you like, of water. So that's why it's important to have a fluid-filled cavity. Now, let's have a look at some pressures, which might also start to explain what's going on slightly with the pleural cavity, the other benefit of having the pleural cavity filled with fluid. Now, I'll deconstruct this diagram. It's not particularly complex, just so you know what you're looking at. These are the rib cage, obviously, in orange, and the diaphragm inferiorly in orange. The airways, obviously, in blue. The trachea and bronchioles aren't shown here. It doesn't matter. And the lung tissue is in pink, and the pleural cavity is in white. So that's what we're looking at. Now, if we look at the pressures, we find that the pressure inside the pleura, which we'll call intrapleural pressure, is subatmospheric, a little less than the atmosphere. So it's slightly negative pressure compared to the lungs and the atmosphere. Why? Start again. How does this happen? We'll talk about in the next slide. Why is it important? We'll address now. So why is it important that the pleural fluid is slightly subatmospheric on average? Now it does change, and you'll see that it changes through the breathing cycle. So this number of -4 millimetres of mercury, which is the unit of pressure, is an average pressure over a period of time of normal breathing. But it does cycle, as we'll see later. Well, what does a negative pressure act like? And I'm asking you to think of the word I'm thinking of, which is very unfair. But a negative pressure acts like a vacuum. And so if you've got this pleural fluid, which is slightly subatmospheric, it's going to act like a vacuum, which is another reason that it's going to ensure that the lungs follow what the thoracic wall does, because it's adherent not only via the membranes, but because the fluid is slightly negative pressure, acts like a vacuum, which makes sure that when the lungs, the thoracic cage expands, the lungs are dragged with it because of that negative vacuum suction, if you like. That kind of makes sense? Why is it negative? I don't care about -4, but why is it negative is important. Let's see the answer to that. The reason the intrapleural pressure is negative, which is important to our function, is because we have some opposing forces at work. Now remember I said that it's nearly impossible to compress or expand water, unlike air. It's not totally impossible. So if you have forces working in opposite directions and the water's in the middle, you will get some expansion of the water, which is going to create a negative pressure. Now, let's look at the opposing forces that cause this negative intrapleural pressure. Well, two are very familiar with us. To us. The alveoli, the lung, there's surface tension. Our old friend surface tension always wants to shrink the lung. Elasticity always wants to shrink the lung. So the lungs are always wanting to collapse or recoil. So they're going to work in an inward pressure. Now, the opposing outward pressure is due to the elasticity of the thoracic wall. And sometimes people get a bit confused about that elasticity. I'm not saying it's as elastic as an elastic band. It's very rigid, but nevertheless some elasticity. Because in fact, if you removed the external musculature and skin and got a knife and sliced through the sternum, you'd find that the ribs would actually flay outwards. They actually, I'm sure you're familiar with the structure of the ribs, and if you're not, have a look at a diagram or a model in anatomy, or go to one of the anatomy labs if you're not doing anatomy. Have a look at it if you need to. The bones are actually connected dorsally to the vertebral column, and basically most of them are connected anteriorly to the sternum. And so they're a curved bone. They don't really want to be curved, and so if you disconnected them, they would straighten somewhat. Not totally, but straighten somewhat. And that's the basis of the elasticity of the thoracic wall. Opposing forces, parietal pleural fluid in the middle, slightly expanded. That's the reason there's a slightly subatmospheric pressure of the intrapleural space, which is important to make sure the lungs are attached to the thoracic wall. So whatever you do to your thorax, your lungs will follow. Okay. Going to lecture 2. Now, I could have run them into each other, but I didn't want to confuse you. I know you've probably printed out them as separate entities, so I just wanted to make sure you're following by keeping them as separate entities. It's not my laziness. There was, no, I don't want security alerts. There. Now, this summary, because it was going to introduce lecture 2, it's the same as the summary I've introduced already, so don't be annoyed with me, please. If I skip this, you've already seen it. It's no new information. I'm going to introduce the second law of physics, and, well, I shouldn't say unfortunately, that's not fair. Physiology gets the phys part from physics because historically physics underpins a lot of our knowledge of physiology and human body. Now, somebody like me who didn't particularly warm to physics and was forced to do it for many years, that's not a good thing, but in fact we'll keep it really simple. And luckily in respiration, the laws of physics are really straightforward. And Boyle's law is one of the most basic principles of physics you could come across. I can't even fathom that anyone would not understand it very easily. All it's doing is linking pressure to volume. So Boyle might have been a genius, but his law is very simplistic. No disrespect to the long-deceased Professor Boyle. But it's saying that there's an inverse relationship between volume and pressure, and that makes total sense. And let's look at this nice diagram from Widmeyer, similar one but not as nice to show in a lecture, from Silverthorne, which shows that very clearly. Here we have a space. Here we have air molecules or liquid molecules, doesn't really matter, just molecules in orange in that space. And the arrows tell you that they're in constant motion. So air molecules, water molecules, particularly if they're warm at body temperature, are always moving. And because they're in a confined space, they will move and hit each other and hit the walls of the cavity. And by hitting each other in the walls of the cavity, they will impart a pressure. It makes perfect sense if you understand that, when you understand that if you reduce the volume of the cavity, but not the number of molecules, they're going to hit the walls more frequently, and the pressure will go up. Decreasing volume, increasing pressure. And conversely, increasing the volume with the same number of molecules, they hit each other in the walls less frequently, so impart a reduced pressure. Increase volume, decrease pressure. Now, I can actually now go backwards and say that kind of explains why when you slightly increase the volume of the fluid in the pleural cavity, why the pressure decreases to become subatmospheric, because by increasing the volume slightly, you decrease the pressure slightly. So Boyle has just proven what we hopefully already understood. It's much more relevant to the next part of the story, though, even though it's nicely positioned to explain the pleura. It will also explain air movement in the alveoli. So let's talk about that story. Everyone happy with Boyle's law? It was, as I said, really straightforward. Now we're going to start putting all our pieces together to come up with the punchline. And that's what's happening in you and I to control ventilation or breathing. And this is a diagram very similar to Silverthorne's, figure 17.8. And it just shows 3 phases of breathing. Now, you can now tell me in very good physiological detail and good chronology, that is time order, what the process of inspiration is. It all starts with stimulating your diaphragm and intercostals. They contract. Thoracic volume increases. Lung volume increases because it always follows the thorax because of that nice intrapleural subatmospheric pressure. When the lung of the volume increases, what did Professor Boyle tell us happens to the pressure when the lung volume increases? By lung, we're talking about all the alveoli. I'm not going to draw, or Silverthorne wasn't going to draw 500 million of them. So alveoli increase in volume. What did Boyle say happened to the pressure? Decreased. So now we have a situation that the pressure inside the alveoli is less than the pressure in the atmosphere. Now, we're connected to the atmosphere. The alveoli are connected to the atmosphere via the nasal or oral cavities, the pharynx, larynx, trachea and bronchioles. So provided they're open, so nobody's blocking your nose or mouth, provided they're open, what's going to happen if the pressure inside the alveoli is less than the atmosphere? Air is sucked into your lungs. How much air is sucked into the lungs? Until the pressures become equal again. There's nothing more complex or technical about breathing in than that. Breathing out, the opposite. Panel D. Don't need to go through the same thing as slowly. I'll go through it quickly because you know it. Breathing out, stop sending action potentials to the diaphragm and intercostals, and hence the thoracic cavity will decrease in volume. So too will the alveoli decrease in volume because they're elastic and have surface tension. Boyle tells us that the pressure will increase if the volume decreases. So now the pressure in the alveoli is greater than the atmosphere. So what will the air in your alveoli, some of the air in your alveoli do? Get pushed out. How much air will get pushed out? Until the pressures become equal again. And that's breathing out, expiration. Don't think of breathing or ventilation as like a balloon because because air gets sucked into the alveoli, unlike a balloon where you're pushing air into it. You're positively pushing air into a balloon. With the lungs, it's being sucked in or drawn in. Expiration is kind of like deflating a balloon, but inspiration is not. Okay, it's just some textbooks talk about balloons, don't like the analogy personally. Now, that's quiet breathing, but as you and I both know, we don't always inspire or expire quietly. But you might have also understood that if you want to take a bigger breath in than normal, what must you do? So if you want to take a bigger breath in than normal, and we'll get to what normal is in a moment. We've got time to talk about the numbers, and I'll do that later. I'm just talking about the theory. You want to take a bigger breath in than normal. What must you do first? Increase the size of the thorax more than normal. Because Boyle tells us if you increase the size of the thorax more than normal, so too will the alveoli increase in size more than normal. And then what will happen to the pressure? It will drop more than normal. So more than normal amounts of air will have to be sucked in until the pressures become equal again. And that's what you and I do when we want to take a bigger breath. We just make sure our thoracic volume is bigger than normal. And same with expiration. What must you do if you want to blow out more air than normal? Decrease the volume of the thorax more than normal. Now let's look at two of those because one's easier to understand than the other. Well, inspiration, you want to take a bigger breath. Well, what can you do? Just contract the diaphragm and intercostals harder, more forcefully, like any muscle, skeletal muscle. And that will increase the volume more than normal. So it's nothing more than sending more action potentials to the relevant muscles of inspiration. But you could also use some accessory muscles. By accessory, they're just helping muscles, muscles that help this process. And Silverthorne figure 17.2 was a really nice diagram, so I used it. Well done, Ms. Silverthorne. The other muscles that are helpful for forced inspiration, by that a big breath in, are the, and I don't even know, anatomists might correct my pronunciation, the sternocleidomastoids and the scalenes. They are positioned so that what can you kind of see what they're going to do? They're going to lift the rib cage upwards more than normal. That's their job. And by lifting it upwards, it's going to increase the volume. As well as the diaphragm and external intercostals that we've already spoken about. They are our key ones. So by lifting, if you take a big breath in, you can actually palpate or feel that your rib cage is moving upwards and outwards more than normal. And that's not only by contracting your diaphragm and intercostals more, you are now recruiting the scalenes and sternocleidomastoids. With expiration, we can't passively recoil a lung more than normal. You can't make a muscle relax more than normal. You either relax it or you don't. So to have a forced expiration, we actually have to recruit some muscles. And so forced expiration, becomes active. It needs muscles. Now, which muscles are going to push your diaphragm up really high or compress your rib cage? Well, by contracting your abdominal muscles, what are you going to do? Squeeze your abdominal contents, your guts. Where can they go? They can't really go downwards. They're going to go upwards to the diaphragm, and they're going to push the diaphragm really high. So the abdominal muscles will help reduce the volume of the thorax and help you breathe more air out, as well as the internal intercostals, which are going to force the rib cage inwards more than normal. Now again, they're only relevant in forced inspiration and expiration, but they do explain that process. Everyone happy with that? Now we get to some physiology. We can leave some anatomy behind. And we look at the physiology, which is basically looking at, we're starting to put some pressures and numbers. It's all very well to have this general idea, and it's really important to have the general idea. We now need to start to come up with some values so that you can provide numbers to, explain all this. Now, a very straightforward diagram, or as straightforward as I could find, but I will take you through it very briefly. The top panel looks at volume, and really accurately it's the volume of the lungs, the alveoli. The change in volume. So in this case it's a change in volume of the lungs. And in the bottom panel we have some the scales are pressures, so we're looking at the change in pressures, and with the pink line we're looking at the change in pressures of the lung, the pink tissue. And less importantly, the grey line equates to the grey part of the diagram, which is the pressure inside the pleura. So let's start to put all these together. What really comes first is, I guess, we're breathing in. And again, most of this is repeat information, so I apologise, but it will add another layer of complexity to what we've already said. You want to breathe in. So we're starting from this point here, point 0. You start to breathe in. You contract your diaphragm, you contract your intercostals. So your thoracic wall expands and your diaphragm flattens. Now that's going to stretch the pleural cavity, isn't it? Because you've increased the force of the rib cage and diaphragm to move outwards and downwards. So you're adding an increased force to the intrapleural fluid. So what's that going to do to the pressure of the fluid inside the pleura? What did Boyle say? You increase the volume very slightly, what's happening to the pressure? It drops. So that explains why during inspiration, the intrapleural pressure, as the rib cage gets bigger and bigger and bigger, the pressure of the fluid inside the pleura, because it's being expanded, gets lower and lower and lower. Now, the lungs will follow that. So you would initially think, okay, if the pressure inside the pleura gets more negative and the lungs are getting bigger, the pressure inside the alveoli will also start to drop and continue to drop during inspiration. Well, we're half right. Certainly during the initial parts of inspiration, as your alveoli get bigger, the pressure drops. But at a key point fairly early on in inspiration, the pressure stops dropping and starts to go back to normal. And there's a very simple answer for why, and that is because air's being sucked in. Now we know that because if we look at the top diagram, we can see air is being sucked into the lungs. And as air is sucked into the lungs, we are actually increasing the pressure again. It's the whole point of breathing. Now let's get some numbers, and don't get too worried about these numbers. How much do we have to reduce the pressure inside our alveoli? The intrapulmonary pressure, inside pulmonary lungs, to get a normal volume of air into our lungs during a normal breath. We only need to drop the pressure inside the alveoli collectively by about 1 millimetre of mercury. It isn't a big change. And a 1 millimetre of mercury drop will move or suck in or draw in, whatever phrase you want to use, about 1/2 litre of air. So during normal breathing, the pressure inside the lungs drops by about 1 millimetre of mercury, and that'll suck in 1/2 litre of air, which is what you and I are doing constantly now. No, not constantly, intermittently now, if you don't breathe constantly. Okay. Now, at the end of breathing in, what did I say earlier? Breathing, inspiration, the air will stop being sucked into the lungs until the pressures become equal again. So let's look. At the end of inspiration, the pressure inside the lung is again the same as the atmosphere because sufficient air has been sucked in to make the pressures equal. That's the whole point. Remember the very first thing I said in the lectures? Air, like most other things, moves down and up pressure gradients. If there's no pressure gradient, there will be no airflow. So if the pressure inside the lungs and the atmosphere is the same, air will not move in or out. And expiration is the opposite. Thoracic cavity reduces, so intrapleural pressure will start to increase again, become less negative. So too will the pressure in the alveoli increase, become more positive. But it'll stop becoming positive once you start pushing air out of the lungs. And once you start pushing air out of the lungs, the pressure drops again until the pressures are equal and air stops being pushed out of the lungs. And that's a typical inspiratory-expiratory cycle. Happens in you and I every 4 or 5 seconds, depending how frequently you are breathing. Now, these values are quiet, normal breathing. Obviously, more forceful breathing will lead to a bigger negativity and hence more air moving into and out of the lungs. Okay. Now, one of the things I like about Widmeyer, and I don't get any money from Widmeyer, so I'm not trying to push the textbook. All textbooks have their benefits. One of the things I personally liked about Widmeyer that Silverthorne doesn't have, Silverthorne is great in other ways, which is why they probably chose to change the book. But Widmeyer does have some nice flow charts. So I just put these flow charts up for you. I happen to think nicely in flow charts. If you don't, that's great. There's no new information here. But if you do like flow charts and linking things together, I thought it'd be nice for me to provide them to you. So I'm going to go through this really quickly because there's no new information. It's just bringing it all together. We have learnt today inspiration, contracted diaphragm and external intercostals, thorax expands, intrapleural pressure becomes more negative than the atmosphere, the alveolar pressure becomes negative, the lungs expand, and air flows into the alveoli. Perhaps I jumped two of those orders about, doesn't matter. So that's a nice flow chart to explain what we've said, if flow charts are your thing. Expiration, slightly extra steps because remember the shrinking of the lungs is all about recoil and elasticity, but it's the same thing. Stop contracting your muscles, the chest wall or thoracic wall recoils, intrapleural pressure starts to go back to its normal pre-expiratory positions, the lungs will recoil, the alveoli become smaller, pressure becomes greater, and air gets pushed out of your lungs. Nothing new there, nice flow chart. As I said, if that's your thing, hopefully that is helpful. Now, let's start to look at a couple of variations, and I'll be fairly quick with the next couple of slides. We're nearly at the end and I've made up time, and hopefully I haven't rushed. Moving air into and out of the lungs is all about pressures. Okay, I agree, that's, and I made these numbers up, 90% of the equation. Don't quote me on that because it's just trying to emphasise a point. But it's not the only thing about breathing. There are two other things that can affect your breathing, and these become quite relevant clinically. And that is resistance and compliance. Now, I'm particularly interested in resistance, and again, in the last lecture I show, and I really don't like the fact the lights are shining on that, I will try and get that fixed. The last lecture I talk about is the clinical relevance of all this, and so this becomes much more important then. But there are other things that can affect your breathing. One of the most obvious is resistance. Now, here is an equation linking airflow to resistance and pressure. And the equation is airflow, the amount of air that moves into or out of the lungs, equals the change in pressure, but also inversely proportional to the resistance. I don't think many of you, but some of you might be saying, I know this equation already, but it just had different words. Any idea where you might have seen this before? Semester 1 or year 1, mean arterial pressure equals cardiac output times total peripheral resistance. So it's the same equation driving blood flow. Blood flow, airflow, same deal, same principle. So this equation tells us that we've spoken about the change in pressure. That's what we spent the last 40 minutes talking about. Let's have a quick look at resistance. Now, why am I only going to spend 2 minutes talking about resistance? Because we're not really designed to change, well, stay in. Resistance will be influenced by what? The diameter of the tubes or airways. Now, why is it not such a big deal in you and I? Because most of our large airways have cartilage which keep them open. So they're unlikely to collapse. With blood vessels, it's really important. For airways, not as important because of the cartilaginous rings. However, it is still important to some degree, particularly in the small airways, because what the airways are made up of smooth muscle, and sometimes temperature can affect the diameter of smooth muscle. As I said yesterday, stick your hands in a bucket of cold water. Your blood vessels, which are also made of smooth muscle, will constrict. Go outside on a very cold morning and go for a run. where you need to move lots of air into and out of your lungs, you will find it much more difficult to do so than a nice warm humid day, because the cold temperature of the air will constrict the airways. Also, if you have asthma, you're probably aware that the build-up of inflammation or mucus can affect the diameter of airways. It is much more difficult to breathe when the airways are compromised in a disease state or a situation that can reduce the diameter of the airways. So for most of us, most of the time, resistance is not a factor. For some of us, some of the time, and for some people with diseases, all of the time, it does become a factor. And we'll leave it at that until we address it at the issue. And lung compliance, another thing that is, for most of us, not an issue. We are how well your lungs inflate and deflate, and therefore the alveoli get bigger and the pressure changes, is how stretchy it is. Now, if you've got a lung that's not very elastic because you've been a heavy smoker, you've got a lot of fibrous tissue because of years of damage, and fibrous tissue is not elastic, scar tissue not elastic, these people cannot stretch their lungs as well. So compliance becomes very relevant for their ability to change the pressures appropriately to breathe air into and out of the lungs. So that will be relevant for some people with diseases all of the time. Emphysema, really classic one. Let's now finish by putting some volumes to all this, and we've got 5 minutes or so to do this, so it is fairly straightforward. This is a nice simple diagram taken from Silverthorne, figure 17.7b. It looks at the volumes and capacities. Now, just as we start, a volume is one change that we're looking at. A capacity is the name they give to more than one volume added together. So don't get hung up about the nomenclature. Volume is a single change, capacity is two or more of them added together. What's relevant? Tidal volume. That's the name we give to the volume of air that you breathe in and out normally. Tidal volume makes sense. 500 mils. Notice that we don't breathe from an empty lung, 500 mils. We don't breathe from a full lung, 500 mils. We breathe somewhere halfway, a little less than halfway. And that makes perfect sense. So our tidal volume works at about 2 to 2.5 litres, a half a litre change every time we breathe in or out. So the tidal volume is 500 mils inspiration, 500 mils expiration. That gives us a lot of reserve. Obviously, we're only working at half our lung capacity, or the mid-range of our lung capacity. You can breathe a hell of a lot more than 500 mils into your lungs. And that volume is called the expiratory reserve volume. It's in reserve, and that's about 1 litre. You also have an expiratory reserve, an